If we're ready, we'll officially start. I'm Linda Topping-Streitfeld. I'm the Director of Programs for the National Press Foundation. Very happy to have all of you here this morning. I want to welcome you. This is our third collaboration with the American Public Health Association. We're very grateful to them for their help in planning this program and for offering their facility this morning. We also appreciate very much the support of Novo Nordisk for this program. We have Ken Inchausti is here in the back of the room from Novo Nordisk, and they have been very helpful in helping us help journalists understand really the elements and context of diabetes as a very significant health problem in the U.S. and internationally. Novo Nordisk will have some materials outside the room, which you're welcome to pick up during a break or on your way out at the end of the day. For those of you who don't know, NPF is an independent nonprofit. We're based here in Washington, D.C., and our goal is to help journalists understand complex issues like the one we're dealing with today, which is diabetes. There's more information about NPF at our website, www.nationalpress.org. And now I'd like to invite Alan Baker to come up and welcome you on behalf of the APHA. He is the Interim Executive Director of the American Public Health Association. Alan?
Good morning. It's a great pleasure to welcome you here today. Since some of you may not be as familiar with American Public Health Association as others, let me just say that we are the oldest and the largest and the most diverse public health association in the world. We represent about 50,000 members, American members, though we do have some international members. And so it's a great honor to have you here with us today. I am the Interim Executive Director, as Linda said. Our Executive Director, Dr. Georges Benjamin, actually has an opportunity this semester. He's doing a sabbatical. So he's actually up at the City University of New York, and he's the Tisch, the Distinguished Fellow for Public Policy. So he's teaching in their public policy program, which is part of their School of Public Health. So that's a great opportunity for him and great opportunity for me to be sort of filling in for him. I know it's confusing to the press because we're doing some press releases where I'm quoted as the Interim Executive Director, and depending on the issue, especially since he's a physician and I'm not a physician, we're doing some press releases where he's quoted as the Executive Director. But, you know, sometimes in public health, things aren't as straightforward as we would all like. But it really is so appropriate. We're here today talking about diabetes. You know, when we know that so many of the things that are important to us in public health, when we look at things from a population basis, where we try to deal with an entire population, not deal with individual one-on-one clinical medicine, we know that so many of the things we stress, a healthy lifestyle, exercise, keeping your weight down, those things are so important for an issue like diabetes. We know that physical activity and not being obese will prevent a large number of cases of diabetes. And we also know that folks who get diabetes, if they're caught early, if they're screened early, if they get appropriate treatment, we can prevent many, many serious complications, blindness, amputation of limbs, things like that. And we also know that some folks who get diabetes, especially adult onset diabetes, if they do control their diet and if they do engage in physical activity, they can actually go back to a non-diabetic state. So this is such an important public health program. With me today is Arlene Stevenson, if Arlene can wave her on. She's the new chief of staff here. I've been here 2 weeks. She and I both came from the Maryland Department of Health and Mental Hygiene. And one of the things we were really proud of in Maryland is the Maryland Medicaid program was an early leader in identifying diabetic care and people who had pre-diabetic conditions and putting them into a special managed care program that we called rare and expensive managed care, because we knew that we could not only provide a better quality of life and reduce morbidity, but we could actually also save taxpayers money by identifying people early, giving them the case management and other services they needed, and preventing complications from diabetes. So with that, I will stop, but let me just say again, it's a great pleasure to have you here today. I hope you learn a lot, and we're thrilled to host this important event. Thank you.
Thank you so much. Well, this is very impressive. How often do you come to a program like this and have it running not just on time, but ahead of time? as I told somebody earlier, I really missed my calling as a camp counselor. So we're going to go ahead and move forward with our first speaker this morning. She is Dr. Sue Kirkman, the Senior Vice President for Medical Affairs and Community Information, and also the Acting Chief Scientific and Medical Officer for the American Diabetes Association. She joined the association in 2007. She has the primary responsibility for the medical affairs area. She oversees the professional practice committee, and she also, as I said, acting chief scientific and medical officer. In that capacity, she oversees all the scientific and medical activities, including the research, clinical affairs, and a variety of other things. Formerly, she was an associate professor of medicine at Indiana University. She was an active clinician there and a researcher. So we really appreciate her expertise this morning, and she's going to open the program by giving us a general overview. What is diabetes? Helping us understand the basics of this disease. Dr. Kirkman?
It is kind of a bit like the interrogation device. Thanks very much. I'm really happy to be here. I was asked to give a little Diabetes 101, just kind of the basics of what diabetes is. If you do know some things about diabetes, I suspect this may be a little bit too basic for you. I don't have an hour's worth of slides. You'll be happy to hear. So I think I can go through most of this, fairly quickly, and then really open it up for question and answer. So hopefully I can answer any questions that you might have. So just a little background, biology. What happens when we eat? So actually, the reason we eat for lots of reasons, but the primary reason that we eat is to provide fuel for our bodies. So we need fuel, we need energy to walk around, we need energy to think, we need energy for our different organs to work, so we need energy for our kidneys to filter waste from our system and so forth. And it turns out that this energy is primarily something called glucose. So when we eat, most of the food is turned into glucose, which is a sugar that circulates around in the bloodstream. It primarily comes from, in terms of immediate use, it primarily comes from the carbohydrates that we eat. But it doesn't matter what sort of carbohydrate you eat, it's going to get absorbed and circulate around in your bloodstream as glucose. So whether you're eating a piece of fruit or a piece of whole wheat bread or a cookie or a Coca-Cola, that will be converted into glucose. The other things that we eat, protein is eventually also turned into glucose to a large extent. And the only fuel that we eat that's not turned into glucose directly is fat. Now, how do we regulate how much glucose is in our bloodstream? We want enough because, again, that's what our tissues are running on. We don't eat all the time. I think in our society we sometimes think that people eat all the time. But, for example, when you're asleep at night, you're going to go for 8-10 hours without eating, and your blood needs to continue to have glucose circulating around in it. On the other hand, we may occasionally eat a lot. So imagine, the contrast between fasting for 10 or 12 hours overnight versus eating a large Thanksgiving meal, where there's this sudden increase in the glucose in the bloodstream. So it turns out the body has very precise ways of regulating that, and despite the extremes, the level of glucose in the blood tends to stay in a very narrow range, and it's really quite elegant the way our bodies do that. A lot of that has to do with a hormone called insulin. So insulin is something that specific cells in the pancreas called beta cells put out, and they help drive the glucose from the bloodstream into the cells, where it's either used immediately for energy or it's stored for later use. And during periods of fasting, insulin sort of shuts off, and sometimes there are other hormones that sort of kick in to make sure that there's enough fuel in the bloodstream when we're not eating. Now, what happens in diabetes? Diabetes is characterized, it's defined by having blood glucose levels in the blood that are too high, and the term for that is hyperglycemia. The blood glucose levels build up and are too high in diabetes for several reasons. One is that too little insulin is made. So if the body's not making enough of the insulin that's supposed to drive the glucose into the body's tissues, then it'll build up in the bloodstream. Another thing that can happen is that the body's cells might not respond very well to the insulin, so they can't use the glucose very well. It can't get into the cells very well because the body is what we call resistant to the insulin that's made. And a third thing that can happen is that the liver can release too much glucose into the bloodstream. So when we are fasting, when we are asleep, or when we're going for long periods of time without eating, the way we can keep our blood glucose high enough so that we can still think and walk around and so forth is that the liver has stored a lot of the glucose, and it releases it sort of gradually so that our blood glucose level doesn't get too low. So it turns out in diabetes, sometimes the liver does that too well or does too much of that. What are the symptoms of hyperglycemia? When hyperglycemia is mild or the blood glucose levels are only a little bit elevated, there may not be any symptoms. But when it gets more severe, the typical symptoms can be increased thirst, increased urination, blurry vision, feeling tired, slow healing of cuts or wounds, more frequent infections, especially things like yeast infections. If it gets very severe, the person can lose weight, sort of unintentional weight loss. And then if it gets very, very severe, there's a condition called ketoacidosis, which is really kind of a medical emergency, and that is characterized by nausea, vomiting, and abdominal pain. So in addition to the unpleasant symptoms that hyperglycemia can cause, it's an even bigger problem because it can cause serious long-term problems. And so these are sort of the chronic complications of diabetes. And they include blindness, kidney disease, nerve damage, so numbness in the feet or painful feet, or nerve damage to things like the stomach or the intestines. Lower extremity amputation is a very feared complication of diabetes. Heart attack, stroke, and problems with circulation, primarily in the legs. There are two main types of diabetes. These are not the only forms of diabetes, but the types that most people have are called type 1 and type 2. Type 1 diabetes, the basic underlying problem is that the pancreas makes too little insulin or no insulin at all. And type 2 diabetes, one of the primary abnormalities is what's called insulin resistance, where the pancreas makes some insulin, but the body just doesn't respond to it very well. So it doesn't help the glucose get into the cells as well as it should. And also in type 2 diabetes, there is a loss of the ability of the pancreas to put out enough insulin over time. So just starting with type 1 diabetes, this is probably about 1 in 10 people. It's possibly 1 in 20. Dr. Albright's going to speak after me, and she may have some better ideas. But it's definitely less common than type 2 diabetes. Most people with type 1 diabetes are diagnosed in childhood or adolescence, but a significant number are diagnosed in adulthood. Used to be called juvenile onset diabetes, so you may have heard that term, and that's because it was sort of thought for a long time that it was a disease that came on in childhood, but that's actually not the case, and so I'm glad that we've actually changed the term away from that because adults can be diagnosed with type 1 diabetes. I've had patients who've been diagnosed in their 70s with type 1 diabetes, so it's not uncommon to be diagnosed in adulthood. In type 1 diabetes, the body can no longer make insulin, pretty much at all. what happens is type 1 diabetes is what's called an autoimmune disease. So we have our immune system, which is the normal system that helps us fight off germs and invaders and foreign substances. And in some kinds of diseases, the immune system, something goes wrong with it and it starts attacking something within our own body. And in type 1 diabetes, the immune system starts attacking the beta cells in the pancreas, and the beta cells are the cells that produce insulin. Type 1 diabetes always has to be treated with insulin. So the problem is the body can't make insulin. The way to treat it is to replace the insulin by taking it through injections or an insulin pump, but basically giving it from some external source. Type 1 diabetes typically comes on very suddenly, and so some of the symptoms when type 1 diabetes comes on are very sudden weight loss, loss of energy, increased thirst and urination, hunger, blurred vision. It's the condition called ketoacidosis, which is the emergency condition that's characterized by abdominal pain, vomiting, sometimes coma. That can also be something that occurs at the time that type 1 diabetes comes on. But typically, type 1 diabetes comes on, very suddenly. So often there'll be a child or a teenager or even an adult, and they're fine. And then over a 3-week period of time, they get very sick, start losing a lot of weight, are urinating a lot. Maybe it's an older child that's been toilet trained for a while. They start wetting the bed again, that sort of thing. Typically, they get very sick. Type 1 diabetes is managed in multiple ways, but typically blood glucose monitoring is important. So the person with diabetes pricks their finger typically, or gets a drop of blood from their finger or their arm or some source, puts it into a little blood glucose meter, and actually measures their blood glucose level. People with type 1 diabetes typically do this many, many times a day because they need to know how much insulin to take. They need to know if their blood glucose is dropping too low, and they need to make lots of decisions about what they're going to do. Education is very important for people with type 1, but also with any kind of diabetes. They need to understand a lot about their disease and how to take care of themselves. Diabetes is a disease where the person is really doing 99.9% of the care, and it's not like every 3 months when they go to see, the healthcare team, that's when their disease is getting taken care of. People with diabetes, type 1 or any type, need to make healthy food choices, be physically active, and as I mentioned before, take insulin. I'd be happy to answer any questions about diet in diabetes, but it's kind of a myth that people with diabetes need to eat a special diet. People with diabetes need to eat a healthy diet, and it's the same sort of diet that all of us should be eating. It's not really special foods. This year is actually the 90th anniversary of when insulin first became available for use. Because I'm kind of interested in history, I just wanted to show this slide. Prior to insulin sort of being discovered and it was figured out that you could give insulin by injections, type 1 diabetes was really a death sentence. And so prior to 1921, people basically, they got type 1 diabetes. They were often put on a very, very low carbohydrate diet, kind of a very, very low calorie diet. To basically just try to starve them, and they would live for maybe a few months and then eventually die. This is a picture of the top picture. This is a 7-year-old boy who had type 1 diabetes, and you can see in the top picture how emaciated he is, and his mother's having to hold him because he's so weak. And he was one of the first patients to be treated with insulin, and the bottom picture is 3 months later. So you can see that that insulin was truly a life-saving discovery. Just moving on to type 2 diabetes. This is by far the more common type of diabetes. So in this country, probably at least 9 out of 10 people, maybe 95% of people with diabetes have type 2. Most people are middle-aged or older when they're diagnosed with type 2 diabetes. This used to be called adult onset diabetes. But it can come on earlier, and as we know, it's actually becoming more common even in adolescents and very young adults. And so that's really a misnomer, so I'm glad that we sort of moved away from that terminology. Type 2 diabetes is more likely in people who are overweight, people who belong to certain ethnic groups, so non-Caucasians, and people with a family history of type 2. So type 2 diabetes tends to run very strongly in families. Many people with type 2 diabetes have a parent or a sibling who also has type 2 diabetes. Type 1 also has some genetic components to it, but it's more common for people with type 1 not to have any family history of it. So it seems to sort of come out of the blue in the family. What are the symptoms of type 2 diabetes? Well, again, it's hyperglycemia, but type 2 diabetes tends to come on very gradually. The hyperglycemia can be not quite so severe. So a lot of people have no symptoms, or they can have very mild symptoms, kind of vague symptoms. You know, they're a little more thirsty than usual. Maybe they're going to the bathroom a little more than usual. They're tired. You know, how many of us feel tired? Their blurred vision, like I mentioned, yeast infections, especially yeast infections in women, for example, vaginal yeast infections. But the symptoms can be, you know, very mild, and they can sort of be mistaken for other things. People are just, I'm getting older, it's summertime, that's why I'm thirsty, that sort of thing. And because the symptoms are not very prominent, it turns out that 1 out of every 4 people in this country who has type diabetes doesn't know that they have it. So about 25% of people with type 2 diabetes are undiagnosed, and they're walking around often for years with hyperglycemia that can be doing damage to their system, but they don't know that they have it. What is the treatment for type 2 diabetes? It often sort of evolves with time, but many of the same things that with type 1 diabetes. Patient education is very important, healthy eating. People with type 2 typically are overweight and need to lose weight, so healthy eating is very important. Blood glucose monitoring and physical activity are very important. And then type 2 diabetes can be treated with oral medications, and over time it tends to need more and more oral medications, so maybe at first the person's on one type of medication, and then a year or 2 later, a second one needs to be added because the blood glucose levels are going back up again. And over time, you know, probably a significant number of people with type 2 diabetes also need insulin to treat their diabetes. What are some of the risk factors for type 2 diabetes? Because it is often asymptomatic, we at the American Diabetes Association really want people to be aware of whether they're at risk for type 2 diabetes. So some of the risk factors are overweight and obesity. It's a very important risk factor. I think people, the general public, recognizes it as a risk factor. The problem is, in some of the surveys that have been done, nobody thinks that that is their own risk factor. So people tend to think they're really not overweight, or that it's not really a problem for them. Being sedentary or less physically active. Family history is, again, very strong in type 2 diabetes. History of gestational diabetes. So gestational diabetes is a form of kind of temporary diabetes that can come on in some women during pregnancy. They're hyperglycemic, typically kind of in the second trimester, 24 to 28 weeks is when it tends to come on. They need treatment during the pregnancy. When the baby is delivered, it goes, you know, the hyperglycemia goes away. But those women are at very, very high risk to develop type 2 diabetes. And in fact, it's been estimated that about 50% of those women will develop type 2 within the next decade. So it's a very strong risk factor. just getting older is a risk factor for type 2. And then, as I mentioned, non-Caucasian race and ethnicity is very important. So African Americans, Latinos, Native Americans have much higher rates of type 2 diabetes than Caucasians. Also, Asian Americans are being increasingly recognized as having increased risk of type 2 diabetes. Now, Dr. Albright's going to speak after me about a lot of the prevalence data and projections of the future, and I don't really want to steal her thunder, but I just want to briefly show some of the CDC maps that sort of characterize where we've come as a country in terms of obesity as well as diabetes. I don't think any of you, I don't think this will be a surprise to any of you that obesity is a growing problem, pardon the pun, in this country. But these maps are really, really dramatic. So this is some of the CDC data from 1991. And as you can see, back in 1991, there were a few states that had 15 to 19% of their inhabitants were obese. But most of the other states, it was below 15% or even below 10%. This is in 1994. That was in 1991. So in 1994, the dark blue is now the over 15%. A lot more states there. Pretty much everybody else is in the 10 to 14% range. This is 2000. We have to have a new color now, because not only do we have over 15%, but we have states that are over 20% now. And you can see that especially in the sort of southeast, a lot more people are getting obese. And then this is 2006. Again, we have a new color now because we have states where over 30% of the inhabitants of that state are obese. And, you know, other states are in the 25 to 29%, 20 to 24%. And these were the heaviest state in the first maps I showed you were the 15 to 19% range, and we don't have many states that are there anymore. And the diabetes so-called epidemic has followed along with this. So if you look at the same sorts of maps, but you look at diagnosed diabetes, you could see that in 1990, you know, there were some states that had a lot. 1994, there were more, and by 2001, again, we have to develop more and more colors because we have states that are now in the 8 to 10% or greater than 10% of their population with diabetes. The other thing that I'm sure is no surprise to anyone is that our children are also getting heavier. And this is just some data that shows that back in the 60s, we really had very few children that were overweight. In the 70s, pretty much the same thing. Around 1980, my kids were born after this, so I'm a little worried, but around 1980, the rates of obesity in all age groups of children just started taking off. And this is very concerning, and I'm sure Dr. Albright will talk to this as well, but it's very concerning to think about the risk for diabetes in the future in younger and younger people because of this. Again, I'm sure Dr. Albright will cover this in greater detail, but kind of the quick statistics on diabetes are that nearly 26 million people in the United States have diabetes. 7 million of those are undiagnosed. So again, typically people with type 2 diabetes that just are not aware that they have it. This is 8.3% of the US population. And because diabetes gets more and more common with age, it turns out that over the age of 65, it's about 25% of people. So if you think about Medicare, for example, a quarter of people over the age of 65 who are on Medicare have diabetes. So you can understand why this is such a big problem for our healthcare system, including Medicare. It's estimated that in 2010, 1.9 million people were diagnosed with diabetes, And so we sort of try to break that down and make it, more understandable. And that's approximately once every 17 seconds, someone is diagnosed with diabetes. So if you just think about spending the day here learning about diabetes, every 17 seconds, someone in the U.S. is being told that they have diabetes. So why is this a problem that there's all this diabetes? It's obviously a big burden to people with diabetes, but also to our healthcare system. Diabetes is the leading cause of new cases of blindness in adults. It's particularly a problem in working-aged adults. It's the leading cause of kidney failure, so the number one reason why someone in the U.S. has to go on dialysis or get a kidney transplant is diabetes. It's the leading cause of non-traumatic lower extremity amputations. I remember talking about this in a group that included lay people, and somebody said, why do we always say that? Aren't all leg amputations traumatic? And what that means is that the number one cause is accidents like car accidents or things like that. But the number two cause, and certainly the primary sort of medical and non-accident cause, is diabetes. Diabetes increases the risk of heart attack or stroke by 2 to 4-fold. It kind of depends on your age as well as your gender. This is particularly a burden on women. So we know that women, especially younger and middle-aged women without diabetes, are sort of protected from heart disease and stroke. They don't tend to have a lot of heart disease, but women with diabetes have a big risk of heart disease. So diabetes sort of really imparts a lot of additional risk to women. Diabetes is thought to be the 7th leading cause of death. That's probably an underestimate because we know that death certificates, for example, diabetes is often not reported on the death certificate, even though the person may have died of a heart attack, a stroke, kidney failure, for example, that was due to the diabetes. Mortality rates are 2 to 4 times greater than people of the same age. So, a middle-aged person with diabetes is 2 to 4 times more likely to die in the next decade than a middle-aged person of the same gender without diabetes. And medical costs are estimated to be $174 billion a year. And just to talk about the cost estimates a little bit more, again, this is total direct and indirect medical costs. So direct costs are things like hospitalizations, medications, dialysis, things like that. But indirect costs are things like you can't go to work because you have to go to dialysis, people taking care of a family member in an unpaid way. Those are indirect costs. And that is for diagnosed diabetes. If you add in the costs of undiagnosed diabetes, so those people also have medical costs, even though they don't know that they have diabetes. If you add that in, plus gestational diabetes, it's probably $218 billion a year.
What year that is?
This is from 2007, I believe, 2007. So, and it's estimated that 1 in 5 healthcare dollars is spent on someone with diabetes in this country, and 1 in 10 healthcare dollars is attributable to diabetes. So the difference between those two statistics is that an 80-year-old with diabetes, for example, might also have a lot of medical costs related to arthritis or dementia or something maybe not related to their diabetes. And so that's where we get the 1 in 5 number, but actually things that are attributable to diabetes, it's 1 out of every 10 of our healthcare dollars. So clearly it's, not only is it a bad disease in terms of the possible complications, but it's also, for society, it's really costing us a lot of healthcare dollars. Well, what about pre-diabetes? I don't know if you've heard of this concept of pre-diabetes. It's estimated that about 1 in 3 Americans has what's called prediabetes. This is typically blood glucose levels are not normal, so they're not in that normal range, but they're not high enough to actually be called diabetes. So they're kind of in an intermediate range. It tends to happen before type 2 is diagnosed, so people have normal blood glucose levels, and then they go through probably many years of having sort of intermediate level, pre-diabetes level blood glucose levels, and then eventually their blood glucose levels get high enough that they can actually be diagnosed with diabetes. I mentioned that 1 out of 4 people with type 2 diabetes doesn't know they have it. It's estimated that more than 90% of people with prediabetes don't know that they have it. So this is all pretty gloomy news, it seems like, but there actually is some good news. Turns out that in people with prediabetes, there's very good evidence from clinical trials that you can reduce people's chances of developing type 2 diabetes by weight loss and exercise. And this is not talking about extreme weight loss. In the clinical trials, the biggest clinical trial is one called the Diabetes Prevention Program. And in that trial, the goal was for people to lose 7% of their weight. So a 200-pound person, the goal was to lose 14 pounds. And that plus things like walking for 30 minutes, 5 days a week, reduced the chances of developing type 2 diabetes by 58% over 3 years in that study. Also, some medications can help prevent or delay type 2 diabetes. A lot of the prevention of type 2 diabetes may actually be more delay, that we're just sort of pushing it out further into the future. Maybe Dr. Albright will mention that as well, or we can talk about it in the Q&A, but that's probably still very, very important. You know, the more years that people have without diabetes, probably the better for their health. The other good news is that even though the complications are really bad, we have lots and lots of evidence for things that we can do that help reduce the chances that someone with diabetes will go blind, get kidney failure, have an amputation. And these include things like just controlling the blood glucose. So, you know, diet, exercise, medications. If you keep your blood glucose levels down more towards the normal range, you're much less likely to develop the chronic complications of diabetes. Controlling blood pressure, controlling cholesterol, you know, making regular visits to healthcare providers, and then early detection and treatment of the complications. Most of the complications have a very long, you know, sort of mild, moderate phase, and it turns out that there are a lot of things that we can do to help prevent the eye problems, for example, to progressing to blindness, or the kidney problems, for example, to progressing to dialysis. So there actually is a lot of good news, and it turns out that for people with diabetes, the chances that they're going to get these devastating complications is actually coming down now. For our society as a whole, some of the complication rates are going up because more and more people have diabetes. But if you have diabetes now, your actually prognosis or your chances of leading a healthy life are much, much greater than they were, you know, 25 years ago, 30 years ago. Preventive efforts are the key, and I'm sure that nobody would disagree with that. Most of the diabetes costs are not the costs of the pills or the insulin. Most of that $174 billion is actually the costs of treating the complications, the end-stage complications of diabetes. And it sort of makes sense that if you invest resources early into delaying or preventing those complications, or preventing diabetes itself or delaying diabetes itself, that will pay off in longer lives, healthier lives, increased productivity, and probably reduce costs over the long term. At the American Diabetes Association, we try to do a lot of messaging to people with diabetes or people with prediabetes, as well as we also have, you know, messaging to healthcare professionals and all kinds of different stakeholders. But, you know, some of the key messages that we just want to get across to people with diabetes are controlling your blood glucose. There's a test called the hemoglobin A1C that we often call the A1C, that we sort of recommend that people try to keep that below 7%. control blood pressure, control cholesterol. Turns out the statin medications are very crucial and have been shown in people with diabetes to really help prevent heart attacks and death from cardiovascular disease. Get help to quit smoking. Smoking is a huge risk factor, obviously, for heart disease, cardiovascular disease, but also for many of the other sort of more specific diabetes complications. And unfortunately, if you look at smoking rates, they seem to be about the same for people with diabetes as they are for people in the general population, which is a little discouraging. Be active, make healthy food choices, take care of your feet because of the amputation problem. So the lower extremity amputations from diabetes are typically because someone has nerve damage in their feet. They don't really feel it if they get an injury or if they step on something or if they have a blister. If they don't really know that it's there or pay attention to it, it can develop into infection, and often there's circulation problems in addition, and it can become a very, very serious problem involving the foot, the lower leg, and that's what leads to these amputations. And then again, get the recommended screenings and early treatments for the complications, because that's so critical in terms of trying to prevent the really bad outcomes. Just at the end, I wanted to briefly talk about the American Diabetes Association, which I hope that all of you will see as a resource to you if you need information about diabetes, or you need to talk to someone about a particular story that's in the news. We do many different things. One of them is we fund diabetes research. So last year we funded about $34 million in diabetes research. We have a grant mechanism where people apply for research grants, and we awarded 338 grants at 125 research institutions, typically universities. And over the years, we've invested more than $500 million in diabetes research. Another critical thing we do is education and information. We do have a toll-free number, 1-800-DIABETES, that anyone can call. We get about 25,000 calls a month. We have a call center with very well-trained representatives, and a lot of the people who are calling are people with diabetes or family members of people with diabetes that need information. But journalists can also call, and will be put through to our communications people to get a spokesperson or information. We have many kinds of health fairs, community events, community programs. We have programs targeting high-risk populations. So we have a program for African Americans that's based in churches. We have a program for Latinos. We have a number of different programs. We have camps. So we run over 100 typically week-long camps for children with diabetes all around the country in the summer. This says we target hundreds of thousands of people around the country, but actually it's in the millions. So some of our African-American program, for example, reached 1.5 million people last year. We publish books. We publish a magazine, a monthly magazine called Diabetes Forecast for consumers. And we also have professional publications. So we publish scientific journals, books for healthcare professionals, and so forth. And then another thing that we do is we publish clinical guidelines. So we have something called the Standards of Medical Care in Diabetes that's put out every year by the American Diabetes Association. Always comes out in January. And I think a lot of healthcare professionals, insurance plans, all kinds of people sort of look to the American Diabetes Association to help figure out what's the best way to take care of diabetes to really make people have better outcomes. And finally, advocacy. I know that Shireen Arendt, who's head of our advocacy area, is going to be speaking this afternoon, so I don't want to steal her thunder, but we do advocate for increased federal funding and state funding for diabetes research. So we advocate, we try to get Congress to fund the CDC more, NIDDK, which is part of the NIH, more, to make sure that diabetes, which is such a common problem and such an expensive problem, really is getting the research funding that it needs to help solve this epidemic. We promote public policies to prevent diabetes or to prevent overweight and obesity. We advocate for affordable, accessible health care, and we also have what's called legal advocacy, which is we fight discrimination against people with diabetes in the workplace, at school, and so forth.
Can you be specific about what kind of discrimination people are seeing?
Sure. There have been cases of, well, I'll give you several examples. So one is just employment discrimination against people that are on insulin. So, for example, the IRS has these people. There's some specific kind of IRS agents, and they actually carry weapons. I don't really know what they do, but there was a case of somebody that had worked for the IRS for many years. He wanted to move up into this specific thing. He was told he couldn't because he was on insulin. And actually, the case went to court. It went to multiple levels of the court. The American Diabetes Association, helped find a lawyer to represent him. Filed briefs and so forth, and that was eventually overturned. Which actually turns out he was too old by the time it was overturned to be in the position, but it set a precedent so that in the future they can't do that. There was very recently a current case that's going on is that an employee of I'll just say a large drugstore chain, national drugstore chain, had diabetes, was at work, got low blood glucose. So people, especially people that are on insulin, if they take too much insulin or haven't balanced eating and insulin, their blood glucose levels can drop too low, can cause confusion and all kinds of problems. The treatment for that is to eat something, so to eat some carbohydrates. So this person was at work. She took a bag of potato chips or some sort of snack, ate it, treated her blood glucose level. Once it was up, she paid for the food, and she was fired. So we are, trying to weigh in on that case and, try to get her reinstated and so forth. And I don't know where that'll go. There also are things with schools. So for children with diabetes in schools, for example, we have a whole program called Safe at Schools, where we try to make sure that children who have diabetes, typically children with type 1 diabetes, have people in the school that can help them with their diabetes. And we try to say that it does not have to be a school nurse, because there is not a school nurse in every school. And so we try to make sure that people are trained, and that the school nurse or the system nurse is helping with that training, but that teachers, other people can help that child, because otherwise it's often, there's a problem, they have to call the parents to come in, or they have to just call 911, that sort of thing.
To clarify on that case you just mentioned, was she fired because they thought she was stealing the potato chips?
I think she was fired, right,
She took it off the shelf and ate it immediately.
She took it off the shelf and ate it immediately and paid for it later, but was still fired, and apparently was like an 18-year employee of large drugstore chain. Well, that has just been, is just now being, I don't know all the legal terminology, but she is just now, taking legal action, so it has not gone to court yet. And perhaps, hopefully it will not, and that there will be some kind of settlement. And
you're tracking that, right?
And we are tracking that, so people often call us. We have a whole network of attorneys that are interested in helping people with diabetes who have issues like this, so we help kind of link people up to the help that they need. And also sometimes we will write an what's it called, amicus brief or something for a case like that. For more information, here are the ways to contact us. 1-800-DIABETES, ask for the communications division. Lauren Gleason is in the blue shirt, is one of our communications people, and so you can get through to Lauren or someone like her. Email media@diabetes.org. And then we have social media. We have a Facebook page. We have, is that a Twitter? thing. Sorry, I don't know. I'm a dinosaur. And then also for the general public, we always just try to get out ways that people can get hold of us. So I think that's all I have. I'll leave that up there in case you want to write any of those down, and then I'd be happy to answer questions.
Yeah, I'm curious if you could.
Oh,
I'm
yeah,
sorry.
yeah.
Can I ask if you
Oh,
have a
sorry.
question? Please
Okay.
step to the mic
All right.
so we can record your voice.
I wish you could help me understand what triggers diabetes in someone healthy, in someone, it's just only the people that are overweight. What triggers this? What do we know and where research is going? Is this
Right.
going to stop one day?
Right. It's a complicated question, and it's probably both type 1 diabetes and type 2 diabetes. First of all, they're different, so they're probably sort of two different reasons, or two sets of reasons why somebody gets type 1 versus type 2. But for either one, it's probably not just one thing. So we know for type 1 diabetes, for example, it's the immune system. Something goes wrong with the immune system. But people can have measures that their immune system is going wrong. So you can measure things like antibodies in the blood, and people can have those but not have type 1 diabetes and never develop type 1 diabetes. So, and people can, and there are genetic factors. So even some things called HLA types, which are sort of some things on the genes that have to do with the immune system. We know that certain HLA types, those people have a much, much greater risk of type 1 diabetes. But on the other hand, some of those, 40% of the population has that HLA type. So it's not that everybody with that HLA type is getting type 1 diabetes. There probably are also some what we call environmental factors in type 1 diabetes. Lots of research has been done, have never quite, nothing's been sort of found that is the smoking gun, but, there's a theory that maybe it's an infection that gets the immune system to go haywire, that maybe it's something in the diet. So there's been a lot of research on things like, if infants start drinking cow's milk at a very early age, is that the problem? Or is it something in our environment? One thing that's very interesting is that autoimmune diseases in general, not just type 1 diabetes, but all kinds of other autoimmune diseases and things like asthma, which is also sort of a problem with the immune system, are becoming much, much more common in the U.S. And one of the theories is that we're too clean, that it used to be that the immune system had to fight off all the farmyard germs and so forth, and that the immune system had a lot to do, and that it was sort of doing what it was supposed to do. And now that we are, that we've sort of tried to eliminate all these germs and infections, there's some thought that the immune system may be more likely to go haywire and start sort of attacking the body. So that's one thing. So even for type 1 diabetes, even though we've kind of found all these things that seem to be related to getting type 1 diabetes, we still don't know why a particular 13-year-old child, suddenly gets it. For type 2 diabetes, we know that insulin resistance is involved. So the body, it just doesn't respond as well to the insulin that the pancreas is making. There's been all kinds of research into, what is that? Why does it happen? But we don't, and it seems to be related to being overweight, but there are a lot of people who are overweight or obese who have insulin resistance, but they never get type 2 diabetes. So again, there seems to be something else, and it may be that it's the problem with the pancreas not being able to make enough insulin to kind of overcome the insulin resistance. So we know that happens, but we don't have a good idea of why it happens. So it's a field where there's a lot of research going on, but it's a little bit frustrating because it seems to be more than one thing. People talk about the cure, we're going to figure out the cure, but if it's something that really has 4 or 5 different causes that are all kind of linked together in ways that we don't understand, it's a little bit harder to know. So long-winded way of saying we don't really know. So people, there definitely are risk factors for type 2 diabetes, for example, all those risk factors I mentioned. But again, people that don't have a lot of those risk factors can get type 2. People that have many of them might never get type 2. It's all just sort of the odds are greater if you have those risk factors.
Just follow up. Is there any study?
Sorry.
Is there any research on the correlation between overweight and diabetes? As overweight has grown dramatically into the
Right.
population around the world,
Right.
has diabetes gone
Absolutely.
at the same level with
Absolutely.
overweight?
And I'm going to let Dr. Albright, she's going to talk about that more in her talk, but absolutely. It's just like those maps that I showed you with obesity is going up, diabetes is going up, childhood obesity is going up, type 2 in children and younger people is going up. Same thing is happening all over the world, especially in countries that are sort of moving from very poor into sort of middle income or higher income. You see this burgeoning of overweight and obesity and diabetes.
Hi, Cheryl Weinstock. The question is, because we know now that women who have gestational diabetes are at increased risk of type 2 diabetes, what should a woman do after she's delivered? I mean, is there a protocol for her when she should check in with her internist?
Right.
And how often? And what is the effect also on her child
Right.
of her having gestational diabetes?
Right,
in
so
the
that's a
future?
great question. So women that have had gestational diabetes, so typically during the pregnancy, women are screened for gestational diabetes at between 24 and 28 weeks, which is when it tends to come on. We were really happy. We actually went to the Institute of Medicine group that was working on the preventive services for women and asked that be included in the preventive services for women in the Healthcare Reform Act, because that makes it so it's not a copay, it's a no out-of-pocket cost to the woman. So there's screening for gestational diabetes during pregnancy, and then there can be treatments during the pregnancy. But then the question is, what should happen afterwards? So two things that should happen. One is that sometimes it's not really gestational diabetes. It's actually type 2 diabetes, more typically type 2, that was picked up during the pregnancy, but maybe the woman was one of those 1 in 4 people that was undiagnosed before the pregnancy. So one thing that's very important is that at the first postpartum visit, which is typically 6 weeks, so 6 to 12 weeks after delivery, the woman should be tested to make sure that she doesn't still have diabetes. So that's one thing that's recommended. Unfortunately, it looks like even though that's been recommended for years and years and people realize it's really important, unfortunately it doesn't happen often enough. So there have been analyses that suggest that fewer than 50% of women are actually getting that postpartum testing, which is a problem. The other thing that needs to happen is, so even if you find out that the hyperglycemia has gone away, we think this was gestational diabetes, those women are at greatly increased risk of type 2. And what should happen is that probably every year, every 1 to 3 years, but probably every year, those women should be tested for type 2 because they are at such high risk. It's one of the strongest risk factors for type 2 diabetes. So that again is something that's probably not happening as much as it should. The other thing is that when a woman had gestational diabetes, the hyperglycemia went away, but when she gets pregnant again, she's obviously at very high risk for getting gestational diabetes again, and it can often come on earlier in the pregnancy the next time around. So those women also kind of need to be screened very early in their pregnancy. So really kind of ongoing, people need to be keeping a close eye on those women. Those women need to be aware that they're at very high risk. Unfortunately, it's a very busy time in women's life, so they often, by definition, they have young children and so forth, and so oftentimes people are kind of lost to follow-up and don't get the ongoing screenings that they need. Yes, sir. I think they want you to use the mic.
You mentioned the surge in autoimmune diseases, childhood asthma. Would you talk a little bit more about that? Does that mean something such as autism or peanut allergies and things which in my childhood I think were unheard of, and now there are lots of restaurants that don't serve peanuts, and lots of kids are taking EpiPens to school. Is that all part of the same issue?
So autism, I think, is different. I don't think that we think of autism as an autoimmune disease, and I don't really know the reasons why autism rates are going up. But yes, I think the allergies, the peanut allergies, as I said, asthma, all kinds of autoimmune diseases, thyroid disease and type 1 diabetes, they're all becoming more and more common in our society. And it's kind of a theory, but it's called the hygiene hypothesis, and there's been a lot of work done on it that it may be because we're kind of too clean now, and maybe my grandmother was right that said you have to eat a pound of dirt before you grow up, and but there've been interesting studies even that if you grew up on a farm, you're less likely to have autoimmune diseases than if you grew up, in the suburbs, for example. So it's kind of an interesting thing. I don't know what we should do with it, whether we should, be more dirty, but yeah. Yes, ma'am.
I have two related questions about diet, but they are distinct. Part one is a lot of the natural living folks who claim some sort of correlation between reduction in diabetes with diets that are, Paleolithic or very low carb, very high protein, and they're saying that people who have presented with type 2 diabetes, when you take out all carbs, and particularly when you take out the high fructose corn syrup, you see reduction, you see reversal, and those people go on to live normal, healthy lifespans or whatnot. The interesting thing to me with that theory is also that the high fructose corn syrup is being implicated in a lot of issues, and being that we're also seeing a lot more fatty liver disease in younger people who imbibe a lot of high fructose containing soft drinks, for example. I wonder if this is just a lot of things that I happen to be reading before coming to this, if the science is starting to bear any of this out.
Right. So it's a very complicated question. It is true that let's just talk about the very, very low carb diets, for example. It is true that there is both anecdotal evidence as well as some studies, they're not the best studies in the world, but that very, very low carb diets, lower blood glucose and help people lose weight, and so forth. And it makes sense. I mean, if you're losing weight, if you're not eating a lot of carbs, your blood glucose levels probably will come down. On the other hand, there also is equally good evidence that a vegan diet, for example, which is very, very high in carbohydrate, extremely low in fat, same thing. Anecdotes and studies as well that show that at least over the short term, people lose weight, people's blood glucose levels, can normalize or whatever. So there's evidence on both sides. One thing to think about, though, is what can people do long term? And so I don't know about you all, but I could never follow a low carb diet long term. I mean, people aren't getting fiber, they're not getting, there are minerals and vitamins that they may not be getting. I also personally would have a hard time following a vegan diet for a long time. So, the question is really, what does that mean long-term for the entire population? We're at the APHA today. Do we really think that everybody in our population should be eating a vegan diet or eating a very, very low-carb diet? If you look at the epidemiology, so we don't have a lot of long-term, randomized trials of you eat this diet and you eat that diet and we'll follow you for 20 years. We don't have any trials like that. We have a lot of epidemiology data, which means that you look at these large groups of people, like the nurses' health study is one, or the men's health study. There are these very long-term studies that are going on where huge groups of people fill out questionnaires and have blood tests, and they get followed over long periods of time, and we sort of figure out who gets diabetes and who doesn't. So it's actually interesting in some of those analyses. It doesn't seem to be carbohydrates that are linked to getting diabetes. At least in men, there was a large study, and in men it seems to be meat intake, especially processed meat intake, that's associated. We don't know if it's cause and effect, but is associated with diabetes. So it's very complicated. And what is clear is that weight gain, however you get there, is obviously a big risk factor. So the other issue is the high fructose corn syrup. So it's very controversial, and some researchers will say they have proof of one and some have proof of the other, whether fructose itself, which is a kind of sugar, which is also in fruit, whether it in particular has bad effects that are different than other forms of sugar or other forms of energy. There's some evidence that they do, there's some evidence that they don't. I think one thing with high fructose corn syrup is it's so cheap. It's subsidized, corn is subsidized heavily by our government. It's so cheap, it's in everything, and the products that it's in are very, very cheap. So even if it doesn't have specific bad effects, obviously if a liter of soda is cheaper than a small container of skim milk, that's where people are going to go. So it's not really clear whether is it specific foods or is it just that we're eating too much of everything. Obviously sugar-sweetened beverages, for example, this is a very hot issue right now, and there's all kinds of issues about taxing them and so forth. And so at the American Diabetes Association, we've been wrestling with this a lot about where are we going to come out on some of these bills that are coming up in different states about taxation and so forth. But I think clearly we all think that sugar-sweetened beverages they have no nutritional value whatsoever, and they're just empty calories, even if the fructose itself or the high fructose corn syrup itself isn't specifically worse than other kinds of sweeteners. But
Just the fatty liver.
I'm sorry.
I'm so sorry.
oh yeah, the fatty liver.
Okay. Yeah, just one last point with that. Any correlation between the fatty liver disease we're seeing, particularly in younger people, and then diabetes?
Right. So that's a really good question. So there's this whole kind of syndrome of fatty liver where people get they get too much fat stored in their liver, and it can cause problems with the blood tests for liver function are abnormal in their bloodstream, and if it gets really severe, it can actually cause cirrhosis. So it's actually fatty liver disease is probably one of the biggest causes of cirrhosis in this country now, fatty liver disease is very much linked to type 2 diabetes and also to overweight and obesity and also to cardiovascular disease. And there's a lot of interesting stuff about insulin resistance being involved and so forth. The issue, again, about high fructose corn syrup and fatty liver disease is it specifically the fructose? I know that the NIH is talking about having a meeting on this in the coming year of high fructose corn syrup or fructose, diabetes, and liver disease, and really what is the relationship. So we don't really know whether it's specifically, is it the high fructose corn syrup, or is it just that these young people are, just consuming too many calories and so forth. So.
This will be the last question, and we'll ask you to keep
Cheryl, I know you had a question, did you?
I'm going to let Laura go and
Okay.
I'll talk to you later.
Okay, that's
Okay.
fine. Yeah, I do need to leave
I
pretty
have
soon, but.
two questions. They're kind of unrelated.
Okay.
One is,
I'm going to ask you, hold it to one and make it concise. Sorry.
okay.
We can talk during the break.
Where are you guys, or are you embracing all viewpoints on the tight control versus moderate control?
So that's a great question. You guys ask great questions. And they're hard to answer because they're very complicated. There's a lot, there's been long-term evidence that hyperglycemia is bad in terms of the complications. And if you look at association or epidemiologic data, the higher your blood glucose, the more likely you are to get those sort of diabetes-specific complications, but also the more likely you are to get heart disease and stroke. So if you're blood glucose levels are really high for a long time, you're at higher risk of heart disease and stroke. So the question is, if you lower the blood glucose with treatment, does that reduce the risk? So there were some older studies that showed that for kidney disease, eye disease, nerve damage, that yes, if you lowered the blood glucose more towards normal compared to not so low, the people that were more towards normal had lower rates of these diabetes-specific complications. But then the big issue is because cardiovascular disease is more common in people with diabetes than those diabetes-specific complications. If you lower the glucose, does it reduce the risk of cardiovascular disease compared to not lowering the glucose so much? So there were 3 big trials that were done, and one of them, the Accord trial, I'm sure you all heard of, was actually stopped early because people that were in the tight control group actually were more likely to die than people in the standard control group. The other 2 trials, which were the Advance trial and the VA diabetes trial, did not show that increased mortality, but all 3 of those trials did not show a significant reduction in cardiovascular disease with the tight glucose control. So what does that mean? The Accord trial showed maybe some kind of harm. The other 2 trials didn't, but none of them showed that it was a slam dunk that we would reduce heart attacks with really, really tightly controlling the blood glucose. Obviously we thought about this a lot and had a lot of people looking at the evidence and so forth. What we did was really said, in terms of the microvascular complications, kidney disease, blindness, so forth, that's the same evidence is still there that lowering glucose is good for those complications. And actually those cardiovascular trials also looked at those microvascular complications and for the most part also showed benefit. So we didn't feel like we should say glucose control doesn't matter anymore. What we did say was, and we had always said this to some extent, but we really kind of tried to say it more, was that you really need to individualize it, so it depends on the patient. So reducing the risk of the diabetes-specific complications takes a long time. And if you have someone who they already have bad heart disease, for example, or they're 85 years old and they have Alzheimer's, or they have a relatively short life expectancy, you're probably not going to get the benefit of the glucose lowering on their diabetes-specific complications because they're not going to live long enough to get them. And so that's probably a group that you should maybe not treat them so tightly, not ignore hyperglycemia because obviously the symptoms are still there and so forth, but maybe not control it so tightly. And then there's a lot of interesting stuff in those studies. It turns out that people in those studies that already had heart disease, that didn't look like there was any benefit in terms of heart disease, but the people that didn't have heart disease, it looked like if you kind of look at subgroups and so forth, that maybe there is reduction in heart disease in those people. Some of the analyses suggested that if you've had diabetes a shorter period of time, there's benefit on heart disease. If you've had it a long period of time, there's not benefit on heart disease. So what we did was really said, for the most part, we're still going to recommend the less than 7%, which is not normal, but that's kind of the general sort of good control for most people, but that you should individualize. And there are some people where you might consider less stringent blood glucose goals. And those include people, short life expectancy, maybe heart disease, advanced complications, and so forth. But it's something that we wrestle with a lot, and it's hard to kind of, there's definitely not a one-size-fits-all recommendation for everybody. So.
Well, we try to plan programs on complicated topics, and I think we've overshot the goal on this one. Dr. Kirkman, thank you so much.
Sure.
We want to present you with this certificate of
Oh,
appreciation
thank you
from the
so
National
much.
Trust Foundation.
Okay.
First of many today.
All right, thanks very much.
This was great. I hope you can hang on for just a couple minutes. I know her time is short, but there were some questions we didn't get to, so I'll leave you.
Yeah, I'll stay for the break, and then I need to go back. But.
Okay, break is 10 minutes. We'll see you all back here at 10:30.